I am going to keep going with OB and GYN surgery. So I am going to go ahead and share my screen. And you guys can follow along with me as I go through the slide. So this will be part 2 of OB and GYN surgery. So we got through the instrumentation and we started talking a little bit about labor and delivery, and we got to the Schroeder-Carr's procedure. So hopefully you paid attention to that part and the certain things to pay attention to anatomy-wise. So I'm starting there instead of flipping straight to C-section for a reason. So I want you to take a look at all of this anatomy on this page. So I'm on page 517. So on page 517, there's a lot of different anatomy, and you need to be familiar with all of it. What's going to help you a lot is this slide right here. This slide will help you understand the different segments and the different ligaments so you don't get them confused. A big one is this broad ligament. So if you look at the broad ligament for a moment, this attaches to the uterus, attaches the uterus to the pelvic wall. So the broad ligament's very important. And a lot of people in the anatomy books don't really understand which ligament is which. So I'm hoping that this paper, this slide, will break it down for you. I usually print it out, so that's why I said this paper. Usually print it out for the students so they can study it. If you are a paper person and you want this on a sheet of paper for you to study, just let me know and I'll print you out a copy, but it's just so much easier to understand in color than in black and white. So as you're studying the anatomy on page 517, if you're having any issues, please use this picture to help you understand that anatomy, especially the adnexa and the broad and all the different paired ligaments. You got 4 paired ligaments that you really need to pay attention to on that page. Okay, so now we can keep going. So let's go to page 519. And I'll go back to where I was. 519, so C-sections. So a lot of scrubs love doing C-sections. You get to see a baby being born. It's a lot of fun. It can also go bad very quickly. So we want you to be very prepared for this surgery. In case something were to go wrong, then you are ready to go. The phrase you'll hear a lot in surgery, or hopefully you will from the good scrub techs, is I stay ready so I don't have to get ready. C-section is a good example. You want to stay ready or whatever might come in the door. So let's look at 519. Look at your equipment, instruments, and supplies. You will need to know all of that, every single one of those bullet points. You'll see that I put a couple on your slide because it's very important to have what you need for this case in order to protect that baby. So looking at your C-section tray, it's going to have a bladder blade in it to protect the bladder and the delivery forceps to help deliver the baby out. Those are just 2 specialty items that are in your C-section instrument pan or tray. Extra supplies that are listed here and in my slide, very important. The bulb syringe, of course that's to get anything out of their nares or out of their mouth. If there's more than one infant, you're gonna need more. And you can think of that with the cord clamps also, because if there's twins, you're gonna need more cord clamps and cord blood containers. So cord clamps, 2 per infant, make that 4 if it's twins. Same thing with those cord blood containers. Taking the cord blood is very important. That's a step that you do not want to miss. So having the clamps and the cord blood containers and the blood gas containers available are very important. You'll do case studies when you're at externship, and you'll have to list things like this, the equipment and supplies that are in the room. So if I asked you on a case study, what equipment do I need in the room? It would be this whole section. So including the overhead radiant heater for the infant, the fetal monitor, the 2 different suction tubes and tips, every detail is what you will list on your case study while you're at externship, because that shows us that you were paying attention in the room, you knew everything that was in the room, and even if you didn't, if you were overwhelmed with just the surgery and the instruments, you have it all right here in your book. So go back to your book, even when you're an extern, and look at all the equipment that was in the room, because there will be a day where there's not going to be someone there to help you. They'll say a C-section's coming up and you just have to have this in your head. You have to know every piece of equipment you need in the room in order to protect that baby. So having a list in your head of what equipment, instruments, and specialty supplies you will need is very important. So if you ever see a slide like this where I make a list for you, it makes it even easier for you. And if it says it twice in your book, it must be important. Make sure you know it. Okay, after that little section, let's go to preoperative preparation. So the position on this one is very important. Make sure you know it. I've had this exact question as a CST question. So the position is supine with a roll placed under their right hip, not their left hip, their right hip. This is to reduce uterine pressure on the vena cava. So this is for their health. It's not just convenience like positioning normally is for surgery. This is because of that pressure that's going to be put on the vena cava. Okay, after that, you'll see that they're going to get a spinal or an epidural, whatever the preference is, and general anesthesia for an emergency. Okay, now you can look at your practical considerations. So the first bullet point talks about emergency C-sections. You need to read through that and understand that sometimes there won't be time to do a count. That's why we're going to do x-rays. But if there's ever time to count, even in an emergent situation, you should count. Now we can look at our second bullet point. The surgical tech should learn how to apply fundal pressure to assist in the delivery of the infant from the uterus. So here's where you can make yourself a little note. So you are going to push on the fundus of the uterus. So where it says apply fundal pressure, that means you're pushing on the fundus of the uterus. You're helping deliver that baby by getting to push on the fundus of the uterus. Kind of cool when you get to help actually do the delivering. Look at your next bullet point. There may only be time for the surgeon and the scrub tech to perform the C-section. So this is where I was talking about stay ready so you don't have to get ready. You want to be ready. So if that surgeon scrubs in and it's just you and them, you can make it through the case. You also want to be really familiar with step-by-step of the case so that you can do a good job assisting if you are put into that position where it's just you and the surgeon doing this together. Okay. After that, it starts going through the procedure step by step. I'm going to skip around, but I will go through it, leaving out lots of details step by step. So let's look at number one. So after your incision, you need to know the type of incision. So hopefully you remember that's fan and steel incision. The most common incision is low transverse. It says they're going to use a 10 blade. I want you to make yourself a little note. They could use a 20 blade. Every surgeon is different. It's up to their preference. So 10 blade or 20 blade. So they're going to make that incision and go all the way through that fascia. Look at your procedural considerations. With anything, when anesthesia is epidural or spinal, there's going to be more communication there. And so you have to remember that if your patient has a spinal or an epidural anesthetic, that means they're awake. They're hearing everything you say. So you don't want to say things like whoops or anything that might put them on high alert. Whatever's going on, they don't need to know every detail. You need to stay professional and communicate with your nurse and your surgeon the best you can without letting the patient hear any news that might startle them or put them under distress. Let's look at number two. So fascia is incised at the midline also. With that 10 blade, it could also be carried out using Mayo scissors. That's what we normally see. So knife across, Mayo scissors across. Lots of bleeding happening after that. So you want to have lap sponges up there. They're going to use some small retractors to retract skin out of the way, usually a Goulet or Army Navy retractor. After that, look at number three. So they're going to find more of a plane and bluntly dissect. You'll see a lot of dissecting with their fingers in C-sections. They're just going to use their finger to dissect through the planes. And if you look at your procedural consideration on number three, they're going to use 2 Coker clamps to clamp onto that fascia. If they need to cut again, they will cut with those Mayo scissors. Now let's go to page 521, number 4. So it's talking about getting into the peritoneal cavity. So cutting into the peritoneum, they're going to use some Metz scissors. After that, number 5, the uterus is going to be palpated. So we're going to see where the fetus is by palpating and finding the right position. So this is when some fetal positions are going to require those delivery forceps to get the baby's head out. After that, you'll see number 6, they're going to actually cut into the uterus. So this is your second incision. We're cutting open the uterus. Now, look at your procedural consideration. The surgical tech should be prepared with that bladder blade to help assist in exposure. So you're helping retract or assisting in exposure under the surgeon's supervision, of course. Okay, after they get into the uterus, they have the bladder blade in, they've done some more dissection. I want you to look at number 8. So number 8, the amniotic sac may not always need to be cut open. So it might just come open on its own. Because of that, look at that procedural consideration. The ST should note the nature of amniotic fluid. So it may require suction and a Deeley suction catheter. The surgical tech should be prepared to keep the field clean of amniotic fluid. To me, what this is saying is have lots of lap sponges up on the field and have suction available so we can keep the field clean for our surgeon. Now we can look at number 9. So to further aid in delivering the uterus, the ST will gently push downward on the upper region of the abdomen. This is what we already learned, fundal pressure. The nares of the mouth and the nares and the mouth of the fetus are going to be suctioned immediately. So by number 9, I want you to put bulb syringe. That means that next step after number 8 needs to be popping that bulb syringe into the surgeon's hand so they can clear out their nares and their mouth, make sure that they can breathe properly. Okay, after that, number 10, umbilical cord is clamped and cut. They usually use Mayo scissors or Lister bandage scissors to cut that umbilical cord. Here's where they're going to take your cord blood samples. Okay, look at number 11. That's when they get to pass the baby off. So we're going to pass the baby off to a neonate nurse. And that's where they have the warmer and everything they need for the baby right next to the sterile field. So you have to be very aware of your sterile field and making sure the other people in the room aren't contaminating your sterile field. After that, they do everything they need to do with the baby. We just take care of the mom. So number 12, the placenta is delivered and put on the back table. Let's go to 523. So we're going to clean everything up on number 13, and then we're going to use oxytocin. So oxytocin may be injected into the uterus to help with hemostasis. Here's what I want you to make a note. Oxytocin is what occurs naturally within our bodies, right? Pitocin is the synthetic version of that. So it does say oxytocin. That's not incorrect. But what is more correct is saying Pitocin, because that's a synthetic version. Oxytocin occurs naturally in our bodies. It's going to have the exact same effect on the mother, of course. The whole idea is to help with hemostasis, and of course, you might already know that that can be used to help induce contractions, but we're talking about C-section here, and the placenta has already been delivered. So we're doing this to help with the bleeding, to help with hemostasis. Then number 14, you'll see they're going to start closing the uterus. So that's when you need to think, I got to start counting, because now it's like an open belly case times 2, because now you have 2 different cavities that you want to make sure there's no instruments left inside of. So now you have to count for the uterus and then for the abdominal cavity. So number 14, the uterus is usually closed in 2 layers. And the procedural consideration, the ST may need to help with exposure during this phase. The surgical tech should request a uterine count as soon as the first suture is handed to the surgeon. So that means you got to get a uterine count to make sure nothing is inside that uterus before you hand that over to the surgeon. So make sure you know that portion. Okay, after that, you can read through the rest of it, but it is closing up and getting all the bleeding under control. If you look at number 17, they could do subcuticular, they could do staples, they could do monocrylon skin. It's really surgeon's preference from here on C-sections. Make sure you read your pearl of wisdom, but I already went over it, so I'll go ahead and flip the page so you guys can see more of a setup. So this is one C-section setup. And I want you to see that every scrub tech is different. Every scrub tech sets it up a little differently. So like for me, this Mayo stand has a little too many clamps on it. I don't think I will need that many for the C-section, but another scrub might want to have more available. So just take a look at these setups and try to get ideas for what you're gonna want your setups to look like when you are scrubbing these cases. Okay. So that brings me to page 524. So I won't flip to another slide because this one's about tubal ligation. So for this one, I need you to go through and study your anatomy. So right here, this anatomy. So for tubal sterilizations, they can tie your tubes right after a C-section, right? So that's why they have it right here afterward. We could go in and do a case that's just a tubal sterilization, tying the tubes. That's open. They could also do it laparoscopically. They could go in and clip your tubes, they could tie it, they could burn them all the way off. There's just so many options. So I want you to read through this case, but know there's so many different ways to deal with tubal ligations. So on page 524, read that first section of anatomy where it talks about the broad ligament, the cornu, all of that area, the fimbriae. You need to be familiar with all of that anatomy. I'm not going to go over every piece of anatomy you learned, so if you have any questions about it, please ask me, but read through that section very well. Let's look at practical considerations. So there's lots of different types of technique for doing this. There's lots of different names. They're named after the surgeon. I want you to look at the Pomeroy technique. So the Pomeroy technique is most often used since it provides the best potential for tuboplasty in case the patient changes their mind and wants more children. So I'm pointing that part out because you will hear more commonly nowadays a laparoscopic tubal clipping, and they use what are called fleshy clips. And they really are just little plastic clips that get clipped onto the fallopian tubes. The reason these are so popular is for this exact reason here. Women change their mind. They say, oh, I actually do want to have one more child. And because it's not completely cut or burned, they can just take that clip off and you can still have a pregnancy if you wish to. So that's why there's so many options, because humans change their mind. Okay. For this one, let's look at page 525. So this gives you a very good visual of what it would look like if it were an open case and the portion of the tube that they're going to be removing. Now, hopefully you remember the Babcock clamp is especially made for clapping around fallopian tubes. So if you look at number 2 on your procedural consideration, the surgical tech may be holding a small retractor, but should have Babcock forceps on the sterile field so the surgeon can easily get it off of the Mayo stand. So they're saying you might be retracting, so you need to have all your instruments up on the Mayo stand ready to go for your surgeon. Okay, so that was your tubal sterilization. Now let's go to tuboplasty. Totally different, but on page 526. Tuboplasty, I want you to look at the surgical anatomy and pathology and understand it's a lot of microscopic. So that's why you see all this microscopic instrumentation and the loops on page 527. So because they might have to do a reanastomosis, see where it says tubal reanastomosis? Again, these are all small microscopic instruments. Look at your pre-op diagnostics, diagnostic testing and procedures. They're going to do an H&P like they do on everybody. I want you to pay attention to the picture, hystersalpingogram. Hystersalpingogram. So they're going to need this image in order to do this procedure correctly. So in order to make the decisions of what to do microsurgically, they need that image to look at beforehand. So that's your diagnostic test for this one. On your equipment, it's super simple. All the microscopic stuff. So microsurgical instruments, operating microscope, or loops. So your loops are pictured on page 527. Those are the glasses with the little loops attached. And your other option is an operating microscope. So that's a big piece of equipment, a microscope they'll have to bring in the room to really zoom in and allow them to do their job. You can flip it over to page 528. It can tell you step by step how they're going to do this tuboplasty, but it's very similar to the anatomy you're going to see on tubal sterilization. So I am not going to go through this one step by step by step. I need you to read through it and ask me if you have any questions about that case. Okay, that brings me to page 530. 530. So laparoscopic resection of an unruptured tubal pregnancy. So laparoscopic emergencies do happen. You will see lots of these because we're really good at doing laparoscopic surgery now. So why open up this patient for an ectopic pregnancy? That's what it's basically talking about. Then doing it open belly. There's no reason to do that. We can do everything laparoscopically now. So laparoscopic resection of an unruptured tubal pregnancy. So look at surgical anatomy and pathology. You need to know what an ectopic pregnancy is. Very common, usually come in the middle of the night. So if you're on call, you'll get woken up for this one. You get to come in and do a laparoscopic procedure. And hopefully this is unruptured like the one in your book. If it's already ruptured, you might have more cleanup and it's going to be harder for your patient to recover, more importantly. But look at ectopic pregnancy. So it's pregnancy that occurs outside the uterine cavity. So we know that this is sometimes in the tubes, but it could be anywhere. It could be anywhere. So ectopic pregnancy is anything that occurs outside of the uterine cavity. That's what I want you to know. Practical considerations. These are going to be laparoscopically treated, especially if they're unruptured. If it is ruptured and it has spilled out into the abdominal cavity, then it's an emergency situation and we're going to do a laparotomy instead. So you'll see exploratory laparotomy for ruptured ectopic pregnancy. Might say tubal pregnancy instead of ectopic pregnancy, but those two terms are going to be used interchangeably. So again, they could come in the middle of the night for an ectopic pregnancy. It's really up to the surgeon to make that decision to decide whether to do it laparoscopic or to do it open. But as you have read already, if it ruptures, they're going to be much more likely to do it open. So they can really get in there and see what all has ruptured throughout the body.